Good day, everybody. I'm Eric Harrison. I work with the Eddie DeBartolo Longevity Meta University. But I'm here to tell you today about something we started quite a long time ago, probably about 2016. It's called Cardio Orthopedics. So we're professionals at bridging silos. We have the DeBartolo Society for Bridging Medical Silos, and that's the parent company of these other companies. We have cardio-oncology, which is a bridge of a silo. We brought these two things together very successfully. And it was important because women with cancer of the breast were getting congestive heart failure and 18% were dying. And we figured out how to spot that and prevent it. So we were successful 9 years ago at doing that and developing that into a whole regimen, which thanks to Steve Caselli and thanks to Dan Linehan. Now, my job was to consider something that I'd seen among patients that was worrying me. And so with 5,000 patients in our practice and a curated patient database, I became worried about patients that had orthopedic problems and also cardiac problems. And so let me give you an example. We had a great preacher that I really liked a lot. And he's had some bypass surgery and some stents. And we took good care of him. His cardiac status was great. And now he's scheduled for hip surgery. And he comes into Memorial Hospital. He's going to get his surgery. The doctors were responsible for him, who are his orthopedist. His orthopedist was an older orthopedist. He had a good anesthesiologist, I believe. He had the surgery. I went to the hospital to see him after the surgery. He was in shock. It was 7 o'clock at night. Anesthesiologist was gone. The orthopedist was gone. There was a chart with no notes. And I had to figure out what to do with this gentleman and why is he in shock. And I had to go get the echo machine. Everybody's gone home. And do an EKG, all these things we had to do. He's dying, and I don't know why. He's not in septic shock. I find that he's bleeding internally, and he's been bleeding since the surgery. He was bleeding in the OR. Apparently, there was a problem regulating his drugs, which he had been on Plavix and aspirin. And I don't know when they stopped them or how long they stopped them. I know they stopped them, and yet he's still bleeding. And unfortunately, he didn't survive that. I felt terrible about that. I started looking at our database of curated patients and trying to figure out what it is that happens to these people. Some of them are bundled. That is, CMS takes responsibility and bundles the payment into $25,000, $30,000, and this is a lump sum payment. If anything goes wrong, you got to give some of that back. So you would say the orthopedist and the hospital has skin in the game. That's pretty important, bundled patients. And so I called these patients who were getting in trouble, who were prolonged in the hospital or were readmitted with problems. I called them bundle busters. I wanted to find out about the bundle busters and what went wrong with them and why. And I looked through the list. I found with patients having knee surgery or hip surgery, all had problems with heart attack. You had to get a stent. You had bleeding. You had pulmonary embolus. you got worse because you were given medicines that suppressed your breathing, which were pain medicines. All these things were very, very complicated. They stopped your anticoagulation before surgery a week before, and you came in and had a stroke. I mean, these are very, very complicated things. And so I said, well, what's wrong? And I tried to find things. And I said, maybe I need to have a different hospital. So I sent the patient to a different hospital. I said, well, maybe I need to have a different operating room and a different operating room. Maybe I need to have a different surgeon. And so we went through all that stuff. And I said, I think what I really need is a different cardiologist. I'm the cardiologist. I'm blaming myself. Why am I blaming myself? Well, I'm using traditional medical treatment on these gentlemen, and for some reason, they're exceeding what my expectations were. And so I decided, after having looked at the database, that maybe if I go forward, maybe I'd do something different. Maybe if we do a pre-op evaluation that's more than just running an EKG, or more than just doing an echocardiogram and saying it's okay. Maybe I need to do a full assessment and I do a cardiac CT, look at the heart, I get the list of medications they're on, I do an echocardiogram, and if I think there's episodes of atrial fibrillation, perhaps I should do a recording of their heartbeat for 3 or 4 days or maybe a week and see if they're having paroxysmal atrial fibrillation. I saw that hypertension was very common. I saw that some of them had dilated aortas. Some people had low ejection fractions. Some people had paroxysmal atrial fibrillation. Some people were on blood thinners. Some people had pulmonary embolus, and they were present before the surgery on the CT scan. Some people had had a previous stroke. And so I found this is a very complicated group that we need to have better understanding than we do, especially the people over 65. And then this gentleman came along who was really a nice gentleman. He was 68 years old, and he'd had a cardiac pericarditis like 15 years ago and had atrial fibrillation at that time. And then he had an endoscopy recently, and he had atrial fibrillation then. So he has paroxysmal atrial fibrillation. So he came over to see me, and I said, we're going to do this CT scan, and we're going to do the echo, and then we're going to see about containing the atrial fib and preventing it and seeing if there's anything else wrong. And so we did the CT scan, and we found a lesion. And we can show you that lesion in here. And it actually was a lesion that I was worried about because it was a setup to have a severe problem. And so you might say the patient might be someone who might get a heart attack. So let me show you back what we found and why that became important. And so here he is. And here's what we found. We found that he had a blockage in his coronary, which was about 70%. But more important than that was there's an ulcer in the middle of this plot. And we said, how is this going to be a problem? Well, you probably don't know, but I do, because 27 years ago, I had a patient that had an LAD lesion from a cardiac cath. I had seen that, and she was going to have a hip surgery of her right hip, and she was in surgery, and I brought the echo machine in and did a transesophageal echo, and I'm looking at her right atrium and her right ventricle, and I see this bone powder come rushing in. It's like a snowstorm. It's like taking a globe at Christmas time and shaking it up and seeing the snow around Frosty the Snowman. And so all this stuff came in and was bone powder, and microscopically you could tell that it had fibrin on both ends, and it was a powerful platelet activator. And so if that activates the platelets within 24 hours on this patient, then that bone powder and platelet activation is going to deposit itself in this plaque ulcer, and it's going to occlude the vessel. So we predicted that was going to happen, told the patient it was going to happen, got a nurse navigator to see him, canceled his surgery where it was going to be at a big hospital with 15 patients getting their hips done, and scheduled him for his hip in a local hospital. And so he comes to Memorial Hospital, has the hip surgery. After the surgery, he's fine. He's sent home the next day, and sitting at home drinking a cup of coffee, he has severe chest pain. And when he had the chest pain, we said, he's going to have a problem, and he knew it. And he said, this is what Dr. Harrison told me is going to happen to me. He called his daughter back to pick him up. He called the nurse navigator at the hospital and said, I'm having chest pain. And they rushed him over, did a cardiac cath, found that this was fuzzy and there was clot in there, and put a stent in, saved his life, saved $20,000. And he went home in just a couple days and he was fine. Wow. So we said, look, we can predict these patients can have a heart attack. Not only that, but we can predict they can have many problems, including atrial fibrillation, dilated left ventricle or aneurysm, pulmonary emboli, coronary artery disease, all these things. And these are the pieces of the puzzle. And these pieces of the puzzle are very, very important. Hypertension, LVH. We can monitor the heart for 24 hours, detect they're going to have atrial fibrillation. They have strokes. They have aortic stenosis. They have thoracic aortic aneurysm, pulmonary emboli. They're at risk of having a heart attack. All these things, and that's why 1 out of 7 patients over age 65 get troponin elevations, which is a blood test we do as a cardiac marker for something going on that's dangerous. It may be non-ischemic. It may be something that's dangerous, but maybe not predictive of a heart attack. So we had those things. So now we've got patients over 65 going to surgery, and we've got to check them. And the cardiology orthopedics group, which is Florida Orthopedic Institute, decided they were going to send their patients to me, and they would pick about 30%. They would be over 70 for sure, some of them over 65. They would be at high risk, and it would be about 30% of the patients. And we saw them, and there were about 500 of them, and we showed 1, they get cardiovascular disease and it's the leading cause of complications. 2, that what is wrong with them is predictable. It is predictable. It's not something that just happens randomly. It is predictable, these pieces of the puzzle. And we actually came up with our own risk score called the Oscar score. And the Oscar score is something that is a number telling you what their risk is, but it's also a number that if we have 30 days to treatment, we can reduce their number before they go to surgery. And they can go to surgery and have outpatient surgery and no complications. So that's what our goal was, and that's what we achieved. And that was the start of cardio orthopedics. So we think that this is something we can apply in other hospitals. And we think it's very important to get away from what we did in the past, which is like a simple EKG and you go to surgery, or a simple echo and you go to surgery. Appreciate that 30% of these patients are at high risk, and we can evaluate that, spot what's wrong with them, contain it, control it. Hypertension, 75% have hypertension, 11% have paroxysmal atrial fibrillation, about 20% have chronic and paroxysmal atrial fibrillation. and such a small percent are at risk of having a heart attack. And so that's what we concluded, and that was the formation of cardio orthopedics. Thank you very much for listening to my conversation. I hope to teach you more about this, and we have a register, and we're going to continue to do the work we've done since 2016, and we also want to promote this nationally. We've given lectures in Baltimore, Toronto, London, and Orlando. And you just got to keep hammering away to make changes in medicine. Medicine's very slow to change. Thank you very much. Bye-bye.